Alright. Evening, everyone. Close enough. I'm going to go ahead and get started. Got three chapters to cover tonight, so we're going to be moving kind of fast. If y'all have questions, please feel free to ask them away. We'll knock those out and get back to it. First chapter we're going to cover tonight is over diabetes and altered mental status, diabetic emergencies, altered mental status. So when dealing with altered mental status and patients having altered mental status, you have to understand what causes that. So your normal consciousness is regulated by your reticular activating system, or your RAS. So your RAS keeps you awake, keeps you paying attention, regulates your sleep. Uh, in order to keep all this stuff going, you have to provide it with three basic requirements: oxygen, glucose, and water. So that's basically what fuels and hydrates and feeds your brain is oxygen, glucose, and water. Your brain has to have those three things to function appropriately. Without any of those three things, you start having deficiencies to your brain being nourished properly or oxygenated properly. You uh, start having altered mental status because your brain's not functioning appropriately. So altered mental status can be caused by deficiencies in the RAS requirements, trauma, infection, chemical toxins. So if somebody beats you upside the head, you're probably not going to act all that normal. If you have some sort of infection or ingested some sort of toxin, it's going to affect how your brain functions, and it's going to make it to where you start having some altered mental status. Uh, Primary brain problems, so problems that originate just from your body's physiology and anatomy can lead to altered mental status, and then problems with another body system can lead to altered mental status. So, for example, if you have a problem with your pancreas, you're not regulating insulin appropriately, your glucose levels are all out of whack. Glucose is one of those things that feeds the brain. It starts leading to altered mental status. Usually you can fix the underlying cause of altered mental status pretty rapidly by identifying and treating that underlying cause. So if we have a patient with low blood sugar, right, and they're unconscious or they're acting all sorts of weird, and we fix their low blood sugar, either giving them oral glucose or on the ALS side, we give them, IV dextrose, things like that, get that sugar back up, that altered mental status fades, and they go back to normal mental status. So when assessing a patient with an altered mental status, the first priority you have is maintaining your safety. Patients who are altered can be dangerous to responders. They can be dangerous to you, your partner, other people around. You need to be sure that you are in a safe situation before you try to assess this patient. So, are they becoming combative? Are they aggressive? Are they violent? Uh, don't ever approach a patient or don't ever, enter a scene that's unsafe. Use law enforcement if necessary. Have them come in, secure the scene, uh, do whatever they got to do, restrain the patient, however that needs to happen in order to make sure that you and your partner and your crews stay safe whenever you're trying to assess this patient. Uh, we're going through your primary assessment, your primary assessment being your ABCs essentially. You need to always pay attention and be considerate of a problem with the airway in a primary assessment when in a patient with altered mental status. So an airway assessment is crucial. So if somebody's altered, we can go and assume that none of their body systems are working appropriately. They cannot function like a normal person should be able to. Therefore, we should assume that they cannot manage their airway or have potential to not be able to manage their airway like a normal alert patient would. So always need to make sure you keep an eye on, keep a watch on that. Uh, Watch for signs of inadequate breathing. Be alert to the need to reposition them, suction their airway, make sure it stays clear. And then if you need to, make sure you're administering high concentration of oxygen if you suspect the patient is hypoxic, having some sort of airway compromise. Be alert for indicators of hypoperfusion. Hypoperfusion meaning shock, things like that. So if the patient is altered, we want to make sure, okay, is their blood pressure low? Are they having signs and symptoms of shock? Can we treat shock as an EMT? Absolutely, we can, in a limited practice. Uh, Another thing you need to do when you're doing your primary assessment is determine the baseline mental status for the patient. Is the way they're acting, is this normal? So somebody who is completely confused and talking out of their head, that may not be abnormal for them. You have a dementia patient, you have an Alzheimer's patient, you have a patient with, some sort of developmental disability. They may have that normal baseline of just being altered and confused and talking weird and not making a whole lot of sense. Uh, Baseline status can be more difficult to determine in children because they answer questions differently than adults. Uh, In these situations, you want to try and refer to the guardian or the caregiver or the parent, whoever's there who's around that child a lot. It's probably gonna be your best source of, information when it comes to assessing that child and establishing their baseline. Ultramental status is considered a subtle sign that there could be some sort of serious underlying issue. So people aren't just usually altered for no good reason. So whether it's they're permanently altered because of a, long-term cognitive disability or cognitive defect, such as a developmental disability, Alzheimer's, dementia, previous injury, something like that, we need to find that out because if it's not, and this is a new, sudden onset of ultramental status or, a new onset of ultramental status, something's causing that. So we need to figure out what's causing that. Need to perform a body system exam, obtain a complete history. This may reveal important information about the suspected cause. Interview family members, bystanders, obtain their baseline, review their medications, look for medical alert bracelets. A lot of people who are diabetic or have heart conditions or allergies or anything else may be wearing these bracelets or these necklaces that detail their medical condition. Make sure you keep a record of how the patient's level of consciousness is over time. When you arrive there, were they alert and oriented, and by the time you got to the hospital, are they now confused and altered? That's something that needs to be noted and handed off to a higher level of care when you get there. Any questions so far? All right. So diabetic patients are very common to deal with in EMS. It's kind of the underlying cause of diabetes is there's a problem regulating insulin and glucose in the body. All right, glucose is a form of sugar. It's the body's most basic source of energy. It's everything you eat is converted into glucose in some form in order for the body to consume it, use it as energy. Uh, Body cells, they require glucose to remain alive to create energy. Uh, After sugar and carbohydrates converted to glucose, it's absorbed into the bloodstream. That's how the body carries it throughout to use it to fuel its cells uh, and use it for energy. Glucose is a very large molecule, and as such, it cannot pass into the cell on its own. That's where insulin comes in. So insulin is secreted by the pancreas when the blood glucose exceeds around 90 in most healthy adults. Insulin binds to the receptor sites on the cells and allows the glucose molecules to pass. So think of it as it's attaching to it, it's opening the door, it's letting it in, it's shutting the door behind it. Uh, Maintaining normal glucose levels in the blood is absolutely essential to maintaining normal mental status. If glucose gets too low, the patient can become altered. If it gets too high, the patient can become altered. So there's a good little graphic to kind of showing that. There's your insulin binding to your cells, allowing the insulin or allowing the glucose to enter into the bloodstream to be carried throughout the body. So then you get into a deficiency in insulin. So patients who are diabetic either do not produce insulin at all, or they do not produce enough insulin, or they've become resistant to the insulin that their body is producing. So the islets of, I never have been able to pronounce that word. I'm not going to try tonight. In the pancreas produce the hormone insulin. Most cells outside the brain use insulin to transfer large glucose molecules across the cell membrane. So, like I said earlier, think of it as a key. It binds to it, it opens the door, it lets the glucose in, it shuts it behind it. It's the gatekeeper to allow glucose into your blood. There's a couple different types of diabetes that are out there. There's two main types. So there's type 1, which is formerly called insulin dependent diabetics. Uh, Pancreatic cells do not function properly. Insulin is not secreted normally. There's not enough insulin. All these things are usually indicative of type 1. Usually, type 1 diabetics are diagnosed as juveniles. Usually, it's an early onset condition. And most all of the time, they are required to take some form of synthetic insulin to supplement their body's inability to produce adequate amounts of insulin or insulin at all. Uh, so those are your type 1 diabetics. You also hear them referred to as juvenile diabetics, things like that. Uh, Type 1 is the ones who it's a lifelong condition. Usually it is due to some sort of deficiency with the pancreas. It's not always brought on by lifestyle choices, diets, stuff like that. There's very healthy people that, up until, in their teenage years, they just collapsed and found out they were type 1 diabetic. It had nothing to do with their diet, their exercise routine, anything like that. Then you have your type 2 diabetics. Type 2 was formerly referred to as non-insulin dependent diabetics. This isn't really a term used anymore because there are type 2 diabetics who take insulin now. Uh, Type 2 diabetics are the body cells are failing to utilize the insulin properly. So this is what I was talking about earlier, where the body's secreting enough insulin, but they don't have, the body's unable to use it. It's become resistant to it. A lot of times, type 2 diabetics are controlled through diet, oral anti-diabetic medications such as metformin, glipizide, things like that. And sometimes they take insulin. Uh, this is usually, but not always, brought on by lifestyle choices, poor diets, poor exercise routines, stuff like that. Not always. There are other health conditions that can lead to you becoming a type 2 diabetic. There's certain medications that can lead to you becoming a type 2 diabetic. But this is usually a reversible form of diabetes. A lot of times people can, excuse, sorry about that. I'm also on duty with the police department right now. So type 2 diabetics are controlled through diet, oral anti-diabetic medication, sometimes insulin. A lot of times, if a type 2 diabetic is diligent enough, it becomes pretty much a non-issue, a non-factor. For example, my dad, he is a type 2 diabetic. It was brought on by his lifestyle choices. He was formerly an alcoholic. He wasn't always the healthiest of person. He became a type 2 diabetic. He started exercising. He started eating right. He's completely controlled by diet. He takes no medication for it, and it's not even a factor in his life. So that's why a lot of type 2 diabetics you'll see controlling it just through lifestyle means. So in our line of work, we're going to deal with diabetic emergencies. So there's two real main types of diabetic emergencies we're going to deal with: sugar's too low or the sugar's too high. Hypoglycemia is the term used for low blood sugar. So talk about, our root words and our fixated words and how do we make it medical terms. So hypo meaning low, hypoglycemia is the condition of low blood sugar. Makes sense? So it's caused by either too much insulin, too little sugar, overexercising or overexertion, vomiting, increased metabolic rate. Basically, the body is unable to maintain enough glucose in the bloodstream to adequately fuel the cells. Hypoglycemia will ultimately lead to ultramental status, unconsciousness. It can lead to possible permanent brain damage and even death if left untreated for long periods of time. So we talk about, the brain needs glucose, oxygen, and water, right? So you deprive it of glucose, there can start being some permanent problems there. So it is an emergency. It does need to be dealt with very quickly and very, effectively uh, as soon as we're called out there to deal with it. So onset's rapid. Signs, they could have normal behavior. They can appear drunk. Uh, they can be stumbling around, staggering, slurring their words. They can mimic stroke-like symptoms even. That's why on stroke patients we always check a sugar. Uh, they can have pale, sweaty skin. They can be tachycardic, rapid breathing. They can start seizing once it starts getting to a certain point. Uh, Quick replacement of the sugar is critical to managing these patients. Oral glucose is often used uh, to help do that at the EMT level. So at the ALS level, we will start IVs. We'll give glucose or dextrose rather via IV, which is an intravenous form of glucose, or we'll give glucagon, things like that. But as an EMT, the pretty much the only thing we have to deal with this at the EMT level is oral glucose. The problem there lies is you cannot give oral glucose to somebody who is unconscious or unresponsive. We don't give anybody anything orally if they cannot swallow, right? And if somebody's unconscious, unresponsive, or severely altered, they do not have the capacity to be able to swallow. All we're going to do is choke them. We're going to create a bigger problem, right? On the flip side of that, you have hyperglycemia. So hyperglycemia is high blood sugar. It's usually caused by an insulin deficiency. Uh, Insulin injections may be forgotten, insufficient. Sometimes they may eat a whole lot and they forget to take their insulin. It happens all the time. Uh, Symptoms hyperglycemia can chronic thirst, hunger, increased urination, nausea, dehydration. Ultimately, they will start becoming altered as well. After a certain amount of time being hyperglycemic, you will progress into a condition known as diabetic ketoacidosis or DKA. DKA is when your sugar gets so high, uh, you start burning fats, proteins in a way that produces excessive waste. You start getting an acid, a very acidotic state, acid built up. Uh, Signs of this will include a profoundly altered mental status, shock caused by dehydration, rapid breathing, and an acetone odor on the breath. The most distinct and identifiable sign of DKA is an acetone odor on the breath. So, a very fruity, acidic type smell, citrusy type smell on the breath is a pretty telltale sign of DKA. Deal with your diabetic patients as always. Ensure your scene is safe. Perform your primary assessment. Identify if they're altered. Perform a secondary assessment. Get the history. Do they have a history of diabetes? Do they have a history of blood sugar issues? Uh, get a history of the present episode. How long have they been like this? When did they start acting like this? What all have they been doing prior to this? Have they had any kind of seizure-like activity? Have they been running fever? Uh, get your sample history. Look for any medical IDs, bracelets, wallet cards. Note any medications. Check to see if they have a home glucometer. If they have a glucometer laying about, they're probably a diabetic, right? Watch for an implanted insulin pump. If they have an insulin pump, they're probably diabetic, right? And then check their blood sugar if your protocols allow you to do so. Determine if the patient is alert enough to swallow. That's going to determine whether or not we can give them oral glucose, right? Take a baseline set of vital signs. Observe for signs and symptoms of a diabetic emergency. So, rapid onset of altered mental status, intoxicated appearance, cold, clammy skin, elevated heart rate, hunger, all these things we just talked about, right? You have any questions so far? Told you we're moving kind of fast tonight. No? Okay. All right. Most diabetics will be in possession of a blood glucose meter. All ambulances will also have a blood glucose meter, and a lot of firefighters, first responders also will have them in their EMS bags. A lot of fire departments carry them now as well. Uh, Blood glucose meters are how a patient's going to check their blood glucose levels. Uh, if possible, an EMT should avoid using a patient's glucose meter. Reason being is in a professional medical response setting, whether that's ambulances, fire departments, things like that, our glucometer should be calibrated. And each glucometer is a little bit different on how it's calibrated and when it's calibrated. But if you're carrying a glucometer, you should be calibrating it as needed. However often the manufacturer says to do that. We don't know when the last time the patient calibrated their glucometer, so we cannot trust the results that it gives us to be accurate. So we should always use the one out of our own kit. It's going to look something like that. It's going to have your meter, your test strips, probably some alcohol preps, some lancets. When dealing with blood glucose measurements, anything less than 60 uh, with and also symptomatic indicates hypoglycemia. In most adults, anything less than 50, you'll start seeing alterations in mental status up to and including unconsciousness. Uh, Typically, anything greater than 140 is hyperglycemia, and anything greater than 300 for longer periods of time will start leading to serious symptoms. So that's where you start getting to that DKA, to that all those symptoms we listed off, the excessive hunger, thirst, dehydration, urination, all that other fun stuff. We start getting that sugar over 300 for an extended period of time. Question or reading that's inconsistent with the patient's symptoms. For example, if you run on me, okay, and I'm sitting here having a conversation with you just like this, I'm fine, I'm alert, I'm oriented, I'm just complaining of, my right big toe hurts, okay? And you check my blood sugar with your meter and it says that it's 9. It's probably not 9, right? So make sure the test strip had enough blood on it, make sure the meter is calibrated appropriately, make sure it's been properly used, properly maintained. It's a piece of equipment, right? It's fallible. It can fail. So always treat your patient, not your equipment. Most glucose meters also have the extreme level readings. So a reading of high in most glucose meters means a reading of over 500. A reading of low in most glucose meters means a reading of below 15. Mild hypoglycemia, minor altered mental status usually can be solved by eating and drinking. You may give them a tube of oral glucose sucked down, encourage them to eat something with some protein in it, something sugary, drink some juice, get their sugar back to the appropriate level. Uh, if the patient's alert enough, they can take the oral glucose tube, squeeze from the tube directly in the mouth, suck the glucose down. It's only a temporary fix. Okay, so the body's going to metabolize that very quickly just because it is pure glucose. So there's not much time for it to break down and everything else. That's why we want to encourage them once they get their mental status back appropriate and everything else, try and get them to eat something solid, some solid food, something the body can use for a little while. Otherwise, we're going to be right back out there doing this again. Patients unable to swallow, they're unconscious, unresponsive, unable to swallow, treat as you would any other patient with altered mental status. Make sure their airway is secure, provide artificial visual ventilations if possible. Uh, Request ALS, do an ALS intercept, or transport to hospital, depending on your situation, right? So, got a lot of that already. Some other causes of altered mental status, you have your seizure disorders. So a seizure disorder is an upset or a disruption of the brain's electrical activity in some way, form, or fashion, right? So the brain is upset by injury, infection, disease. The electrical activity will start becoming irregular. Uh, Irregularity will cause a sudden change in sensation and behavior or movement that we call a seizure. So not all seizures are the full flopping on the ground like a fish, things that we see. There's a lot of different types of seizures that we'll deal with. So partial seizure will affect only one part of the brain. It may involve an uncontrolled convulsion in a patient with fully alert mental status. Some patients may briefly lose consciousness without any convulsions. Uh, Generalized seizures, on the other hand, will affect the entire brain and affect the consciousness of the patient. The most often thing that we're called for is a tonic-clonic seizure, which is a generalized seizure characterized by unconsciousness, major motor activity, so the full shaking, rigidity, everything you'll see. Uh, Usually will have no warning. They will thrash wildly, and the entire body is involved. Tonic-clonic seizures have three phases. You have your tonic phase, which is where your body tenses up, hard as a rock, straight as a board. Breathing may stop for a second. Bowel and bladder control may be lost and may urinate or defecate on themselves. Then have your clonic phase following that. The body will violently jerk for 1 to 2 minutes. They may foam at the mouth. They may become cyanotic. Uh, Following this, you will have the postictal phase. That's where the convulsions stop. They will regain consciousness and they may be drowsy, violent, altered, confused, everything else. Some seizure patients have what's called an aura prior to them having a seizure. That's a change in smell, sound, general feeling. It's usually called an aura. Most patients, the aura is going to be the same every time. Not always, but most patients have the same aura every time before a seizure. They usually will know when a seizure is about to happen, especially ones who deal with this often, and they will a lot of times will sit down, lay down, something like that prior to it happening. The most common cause of a seizure in an adult is a failure to take the prescribed anti-seizure medications. Usually, when an adult has a seizure, they have most of the time they have a seizure disorder. They did not take their seizure medications, and surprise, surprise, they had a seizure. Not always. Most common cause of seizure in infants and young children is a high fever. We call that a uh, excuse me. So some other causes of seizures are hypoxia, stroke, traumatic brain injury. Uh, Excuse me, I'm sorry, I'm backing up. We call the seizure with high fever a febrile seizure. I just realized I didn't finish my sentence. I apologize. Uh, we call it a febrile seizure. Other causes of seizures can be hypoxia, so not enough oxygen, stroke, so the brain has a bleed or some sort of clot in it, causes stroke-like symptoms, can also lead to seizure-like activity. A traumatic brain injury, so if somebody is injured, has a head injury, they can seize. Ingestion of toxins, so drug use, poisoning, things like that, that can cause seizures. Hypoglycemia, like we just talked about, can lead to seizures. All these things can lead to seizure-like activity. So epilepsy is a term you hear a lot of times. You'll hear somebody's epileptic. It's an umbrella term. Okay, so it's used to describe somebody who has multiple seizures of an unknown cause. They can't pinpoint it. They just have seizures. They may be present from birth. It may develop later due to injury or surgery. Uh, Most people who have quote unquote epilepsy take anti-seizure medications, anticonvulsants. They live a normal, happy life without seizures. They're fine. Uh, When doing your assessment on a seizure patient, if you witness a seizure, it's important to describe what happened in the seizure to emergency room personnel whenever you get there and hand off your patient. Uh, Gather as much information as you can from the bystanders. Ask questions. What were they doing before the seizure started? Did they say there was an aura? What did the person do during the seizure? If they weren't seizing when you got there, what exactly did they do? Were they thrashing around? Did they get real tense? Did they just lose consciousness? What did they do? Uh, Observe, see if there was a loss of bowel or bladder control. Ask how long did it last? If it was still going on when you got there, ask how long did it last? Ask what the person did after the seizure. Were they confused? Were they altered? Uh, if a patient is seizing on arrival, they are a priority transport. If you're present when a convulsive seizure occurs, place the patient on the ground. Loosen restrictive clothing. So unbutton top buttons, take stuff away from around their neck, things like that. Remove any objects from the area that may harm the patient. Okay. So chairs, tables, sharp objects, anything that they could hit, knock down, anything that has hurt and injure themselves, get it away from them. Uh, Protect the patient from injury, but do not try to hold the patient still. They will tense against you with such force and strain that they will injure themselves if you try to hold them down. If the patient has a vagus nerve stimulator, which is an electrical contraption attached to the patient through wires go up to the nerves, and usually is activated by a magnet, let the family members apply the magnet to stop the seizure. After the convulsions have ended, the seizure is over. Protect the airway. If they're cyanotic or hypoxic, provide artificial ventilation with oxygen, provide supplemental oxygen as necessary, open the airway, suction, and clear the airway, maintain the airway at all costs, and then transport them. Treat any injuries they've sustained during the convulsions and transport. Never place anything into the mouth of a seizing patient. I'm sure we've all seen a movie where somebody starts having a seizure and they get this big old bite block thing and force it into their mouth. Okay, don't do that. Uh, what you're going to end up doing is you're going to injuring them. You're going to chip their tooth. You're going to break the tooth. You're going to make them salivate more. You're going to make them choke. You're going to do all these other things. It's going to create more problems than it fixes. If they bite their tongue, they bite their tongue. We'll fix it. We'll deal with it. Don't put anything in their mouth. Uh, Two or more convulsive seizures in a row, or a single seizure lasting more than 10 minutes is called status epilepticus. It is a life-threatening condition. It requires immediate transport to the hospital, and it's going to require ALS interventions. We will have to give this person sedatives of some sort. Usually we'll give a benzodiazepine, such as Versed, and the brain's ability to, we're going to stop the brain's ability to make the muscles constrict and spasm like that in order to try and restore blood flow and everything else. It's a life-threatening condition. What you're doing is basically you're depriving the brain of any kind of oxygen throughout that entire time. So you're going to start leading to long-term damage up to and including potentially death. Some other types of seizures you may deal with is a simple partial seizure. May involve tingling, stiffening, jerking of one part of the body. They may have an aura with this. There's usually no loss of consciousness. In some cases, it can be a precursor to a full tonic-clonic seizure. So you may get there and somebody's just randomly or just uncontrollably shaking their left hand. Okay, take note of that. That could be a partial seizure. Okay, it could be a precursor to a larger seizure-like activity. Complex partial seizures are usually characterized by abnormal behavior. So it may involve confusion, glassy stare, aimless motion, fidgeting. Patient may appear to be drunk. Uh, Usually, this is preceded by an aura. Uh, Patients aren't usually violent. They may struggle against you if you try to hold them. There's usually no loss of consciousness, but there's also usually no memory of the episode. Uh, we categorize this as an absent seizure, or a petit mal seizure. It is basically pretty much where they just stop. They may stop mid-sentence. They stare off into space for 10, 20, 30 seconds. Uh, it may occur hundreds of times per day. It does not usually involve any motor activity. Sometimes people have them all the time. Don't have any idea of it. Uh, this is one type of generalized seizure, the other type being the tonic-clonic seizure we just talked about. Any questions about seizures? Comments, concerns, donations? Some other causes of altered mental status, you have your strokes. So stroke is death or injury of brain tissue from oxygen deprivation. An ischemic stroke is caused by a blockage that occurs due to clot or embolism obstructing an artery. So the brain has a clot or an embolism, it's blocking off blood flow. Blood cannot be carried to the rest of the brain, causes injury to that part of the brain, right? Uh, Other type of stroke you deal with is a hemorrhagic stroke. Hemorrhagic stroke is caused from bleeding from a ruptured blood vessel in the brain. So, you have a blood vessel that bursts, blood starts spreading throughout the brain. Usually, it's a result of a long-standing high blood pressure. It can also occur when a weak area of an artery bulges and eventually ruptures. We call it an aneurysm, right? Different patients exhibit different signs depending on size, location of the arteries involved in the stroke. One side of weakness is very common. We call it hemiparesis. So they have complete left or right sided weakness or paralysis on one side or the other. Difficulty speaking, complete inability to speak. So they have that slurred words, may not make a lot of sense. Have dysphagia where they're just saying nonsense words. Uh, Severe headache, deviation of the eyes, inability to recognize parts of their body. These are all signs and symptoms of a stroke. So when communicating with a stroke patient, you got to remember that sometimes they will have aphasia. So aphasia is just kind of a blanket term for difficulty communicating. When a patient has expressive aphasia, they know what they want to say, but the wrong words come out. Well, that's the nonsense words. They just come out saying just random words that have no business and no bearing on anything that you're trying to talk about. They know what they're trying to say if they can't get the words to come out appropriately. Uh, in receptive aphasia, the patient has no idea what you're talking about. They do not understand what you're saying, so they may respond to you in a way that is completely inappropriate, has no idea, does no bearing on what you're doing, because they don't understand what you're saying. They think they know what you're saying, but they think you said something completely different than what you said. Another form of altered mental status can be caused by a transient ischemic attack or a TIA. TIA is when a patient exhibits stroke signs that resolve on their own within 24 hours. Usually, this is caused by small clots that temporarily block circulation of the part of the brain and will cause stroke-like symptoms. Symptoms resolve when the clot breaks up. Period of hypoxia is short, and there's usually no long-term damage because of it. It's incorrect to call this a mini stroke because it's not really a mini stroke. All right, but it is a potential precursor to a full-blown stroke. So a TIA is oftentimes a warning indicator that a larger stroke may follow. Meaning because the piece of the clot that came through and blocked part of the artery, could have broken away from a larger clot. It could be indicative of the patient that's already got clots forming, clots building. They should be evaluated as soon as possible to see if they can maybe ward off a stroke before it happens, kind of thing. When evaluating a stroke patient, you want to perform the Cincinnati pre-hospital stroke scale. So basically, this is the BFAST exam. Ask the patient to smile. Uh, if there's no movement or an unequal movement, once to one side or the other, that's a fail. Ask the patient to close their eyes, extend their arms straight forward for 10 seconds. Abnormal response is one arm to drift or not move, or for the arms to turn. Like that, be arm drift, that's abnormal. Ask the patient to say a phrase. They use the example here. You can't teach an old dog new tricks. If they have slurred speech, the wrong words, no speech, it's a fail. We look for facial droop like this guy has here. So pretty much the only thing you can do pre-hospital for a stroke is recognize that it's a stroke. Uh, there's several conditions that can mimic a stroke, such as hypoglycemia we talked about earlier. It's always better to overtreat a suspected stroke because even if you're wrong, you still get them to the hospital in a very rapid fashion. Even if it's not a stroke, they can take care of what it is, no harm, no foul, right? But if it is a stroke and you undertreat it, you ignore it, you don't recognize it, you could be potentially delaying care for them. It is time sensitive. The longer the vessel's blocked, the longer the brain is not being perfused, the more damage that will occur, the more likely the effects of the stroke will become permanent. Patients conscious and can maintain their airway, calm and reassure them, monitor their airway, administer high concentration oxygen if they're below 94%, or if they're hypoxic or the patient is in distress, and then transport rapidly. Uh, if patient's conscious or cannot maintain their own airway, open their airway, provide oxygen, artificial ventilation if necessary, and then transport rapid. Any questions about strokes or TIAs? Some other causes of altered mental status, dizziness and syncope. These can be warning signs of serious or life-threatening problems. Uh, you may be unable to diagnose what caused the syncopal episode, but you can treat the life threats to gather information. Uh, Determine what the patient means by dizziness. Are they just weak? Do they have vertigo, which means like the room is spinning? Do they have lightheadedness? Uh, a syncopal episode or syncope is a brief loss of consciousness with a spontaneous recovery. Uh, Patients will often have some warning signs syncopal episodes about to occur. So you get the tunnel vision, the blurry vision, the spotted vision. They may have lightheadedness, dizziness, vision changes, sweating. In some cases, they may lose their bowel or bladder control, similar to they would in a seizure. Uh, some common cardiovascular causes: bradycardia or tachycardia, so too slow, too fast. Acute myocardial infarction or quote unquote heart attack. Abnormal heart anatomy. Sometimes you have people who have conditions where the heart is deformed or doesn't function the way most people's hearts do. Uh, Sensitive carotid sinus or stimulation of the vagal nerve, which is a vasovagal syncope. So, most common example of that is if you bear down too hard on the toilet, for example, you get a little lightheaded, you get a little weak, woozy after that. That's a vasovagal syncopal episode, pretty much. Also be caused by hypovolemia, so low fluid or blood volume. Uh, be caused by metabolic or structural causes, inner ear problems, hypoglycemia, stroke, seizure, caused by environmental or toxicological causes, so alcohol or drug use, carbon dioxide poisoning, panic anxiety attacks, drug use. Uh, in more than half of syncopal episodes, however, there's really no causes that were found. They just passed out. They just fainted. Uh, that's usually the end of it. No problem after that. Treat them for any symptoms they have or any injuries they occurred. Take them to the hospital, let them evaluate them. They'll go home. Performing a patient assessment, determine what they mean by dizziness. Do they have any warning? When did it start? How long did it last? What position were they in? Do they have any similar episodes previously? Are they on any kind of medications? Do you have any other signs and symptoms? Are you feeling anything else? Are you lightheaded? Do you have a headache? Are you weak? Uh, did you hurt yourself? Uh, did anybody witness any involuntary movements of the extremities? Trying to rule out a seizure. So you want to ensure the patient's in a safe environment, help the patient to a safe position on the floor. If you are around when they pass out, uh, catch them pretty much. Provide aftercare, lay the patient flat, loosen tight clothing around the neck, administer oxygen if needed, call for ALS, treat any injuries. All right. Any questions, comments, concerns, donations about any of that? Move through that kind of fast. Just pulled up here. Bear with me just a second. Just a second. I'm trying to get pulled up. Being slow. All right, there we go. Next chapter is going to be about allergic reactions. So allergic reactions occur when the body's immune system responds to some sort of foreign substance in the body, and it's basically the body's way of trying to get rid of them. It's an exaggerated immune response. An allergen is what we call a substance that causes an allergic reaction. So it's the substance the body's trying to get rid of. Anaphylaxis or anaphylactic shock is a severe, life-threatening allergic reaction. So in anaphylaxis, the blood vessels will dilate rapidly, causing blood pressure to drop, hypertension. Cells leak fluid into the interstitial space, the tissues swell, including the airways. So start getting hypoperfusion, uh, constricting the airway, starts becoming a life-threatening condition. They can't breathe, right? So some causes of allergic reaction, you have insects, uh, bee stings, yellow jacket stings, wasps, hornets, food allergies, plant allergies, medication allergies, or other environmental causes, dust, chemicals, soap, makeup, stuff like that can cause some form of allergic reaction. Latex allergies are a particular concern in EMS. It's not as big as it used to be. Most hardly anybody uses latex gloves anymore. Used to, especially, I mean, even not that long ago, back when I first started, 7, 8 years ago, latex gloves were still pretty common. Uh, a lot of patients, we discovered a lot of people have latex sensitivity. Uh, Patients who have had multiple surgeries are more likely to have latex sensitivity. Uh, and wearing latex gloves while you're providing care can lead them to have an allergic reaction. Most EMS providers, most hospitals even now have like vinyl type gloves. Uh, we're not really using latex gloves anymore. It's not that big of a concern anymore. An allergic reaction does not usually occur the first time a person encounters an allergen. On the first time the body's exposed, usually the immune system will form antibodies. Uh, on the second exposure, the antibodies combine with the allergen to combat the allergen. Uh, this causes the uh, release of histamines. This substance can cause a spectrum of reactions. The spectrum of reactions on allergic reaction can be the dilation of blood vessels, which reduces the amount of blood return to the heart. So you get patients who are hypotensive, low blood pressure, all that other fun stuff. Skin becomes flushed as blood vessels near the surface open up. The patient will develop angioedema as fluid moves into tissue, so their arms, legs might start swelling, might start getting swelling around the vocal cords, start leading to difficulty breathing. Uh, May develop hives on the skin. They have bronchoconstriction that decreases air movement to the lungs, development of thick mucus in the lungs. Uh, the exact course of allergic reaction is unpredictable. That's why it's so dangerous. So severe reaction can be immediate. It can happen as soon as you come in contact with that allergen, or it can be delayed. It can happen, 30, 45 minutes, an hour later, and you just don't really know. A mild allergic reaction can rapidly progress to anaphylaxis. So you want to treat any kind of allergic reaction with you know a great seriousness because it can progress to full-blown anaphylaxis, which is the life-threatening condition. So allergic reaction may include facial swelling. So he's got kind of some redness, rash, some hives forming around his skin. His face is swelling. Uh, Developing hives around his skin, red blotchy itchiness. They're not fun. I've had an allergic reaction to some medication one time, broke out in a terrible case of hives. They itch terribly. They don't go away for a day or two. Uh, Signs and symptoms of allergic reaction. You can also have respiratory issues, so tightness in the throat or chest, cough, rapid labored and noisy breathing, uh, hoarseness, muffled voice, loss of voice, stridor, wheezing. Wheezing is a pretty common telltale sign. It's not the only sign of allergic reaction. You also have people with stridor, which is the high-pitched breathing. Uh, you have cardiac signs and symptoms, so you have increased heart rate, decreased blood pressure. So heart rate goes up, blood pressure goes down. That's a very common sign of it. You have your generalized findings such as your itchy, watery eyes, headache, runny nose, sense of impending doom. Like you get there and they feel like oh my God, I'm gonna die. Uh, they feel like they have that sense of impending doom about them. So to be considered anaphylaxis, the patient must have have either respiratory distress or signs and symptoms of shock. So they must have some sort of signs and symptoms of shock, so the hypoperfusion uh, or respiratory distress. Respiratory distress with anaphylaxis is the most common. You'll have the closing of the throat, the swelling of the airways, feeling they can't breathe. That's the stridor, low pulse ox, hypoperfusion. It's a very serious condition. Dealing with a patient having allergic reaction, perform your ABCs, care for any immediate life threats, open the airway if need be, provide artificial ventilations, provide supplemental oxygen, treat for shock, all that other stuff. During your secondary assessment, inquire about the history of allergies. Try to figure out what they were exposed to. Are they allergic to shrimp and you respond to a backyard shrimp bowl? Ta-da, you solved the mystery. Uh, how was the patient exposed? Did they touch it? Did they eat something? Did they smell something? Did they breathe in something? Figure out what signs and symptoms they're having, obviously. Figure out if it's progressed. So, how bad was it when you called versus how bad is it right now? And then provide any interventions. Or have they provided any interventions? Have they taken Benadryl? Did they use an EpiPen before you got there? Get a baseline set of vital signs. Get the remainder of your history. Monitor the patient's airway and breathing. Apply high concentration of oxygen. If patient's not breathing, adequately provide artificial ventilations. Uh, Big thing is determine whether or not you should assist the patient with an epinephrine autoinjector, an EpiPen. So we would use an EpiPen if there's a signs and symptoms of anaphylaxis. If it's just a simple allergic reaction, there's some localized symptoms, stuff like that. We're not going to worry about. We're not going to mess with an EpiPen, right? But we have somebody who's in full blown anaphylaxis, having the respiratory issues, having hypoperfusion, signs of shock. We're going to give an EpiPen. Some services require you to consult medical direction before you use an EpiPen. Refer to your own protocols on that. If you use an auto injector, you administer epi from your ambulance or from your fire department. Record that you administer it in your PCR, obviously. Sure the patient gets transported, reassess every 2 minutes. Uh, if your patient meets the criteria for epinephrine, but you cannot carry and use it, call for an ALS intercept. EpiPens are kind of a weird topic. There's some people who or some places that you let you use them as EMTs because it's within your scope of practice as far as the national thing goes. There's some places that make you call for ALS intercept, some places that make you call for medical control orders. Go to your local protocols on it. So what epinephrine does is it constricts blood vessels and it dilates the bronchioles. So where your anaphylactic reaction uh, dilates your blood vessels and constricts your bronchioles, this does the opposite. Okay, so it fixes the life-threatening aspect of the anaphylaxis. It does not, however, stop the allergic reaction from happening. It does not stop the histamine reaction. Uh, a lot of times, patients who have severe allergies will have EpiPens. Usually, they come in a pack of two. They usually kept at home by the patients or they're carried around with them. They're spring loaded. They have a single dose of epinephrine inside them, and they come in adult and child sizes. The only difference is the adult size has zero point 0.3 milligrams epi, child size has 0.15. You don't really need to know that. You just need to know adult versus child. Before you administer an EpiPen, check the expiration date. We do not give expired medicines uh, to patients. Ensure the liquid is clear. Remove the cap, press the injector firmly against the outer thigh, uh, midway between the waist and the knee. Hold it in place till the entire dose is injected. You usually want to hold it there about 15, 20 seconds. Reassess after 2 minutes. So the pulse will likely increase, symptoms will likely decrease. Uh, EpiPens may be dangerous for a patient with a heart condition or is hypersensitive. So is not breathing. Okay. So you want to make sure that if they're in anaphylaxis, you have access to EpiPen, give it to them. Used to, the thinking was that we should only give an EpiPen to somebody who's been prescribed an EpiPen, right? That's the thinking has changed. Epinephrine is not a tailored drug. There's a universal dose for adults. There's a universal dose for children. That's why most systems in most states, including Arkansas, allow EMTs to carry and administer EpiPens. But as always, follow your local protocols. Some states and some systems, including Arkansas, allow you to administer epinephrine from a vial. Basically, you draw it up in a syringe and you give it. That is approved skill for EMTs in Arkansas as well now. The ready check inject method is commonly used. So usually they will carry, most places carry a 1 ml vial or ampule of epinephrine. Verify the dose drawn up. So 0.3 mLs for adults, 0.15 mLs or 0.15 milligrams because it's 1 to 1 for children. Intramuscular needles and syringes are used. A lot of times when these are carried on a BLS ambulance, they'll be all packaged together along with a review card that basically has a step by step of what you need to do. Anybody have any questions, comments, concerns, donations over allergies or anaphylaxis? Do speak up, let me know. One more chapter for tonight. Please make sure you're doing your reading as well. All right. Last chapter we're going to go over is infectious disease and sepsis. All right, so infectious diseases are caused by bacteria, viruses, other microbes. Uh, you have communicable diseases, which are spread through direct contact or contact with secretions. Uh, if an infection causes an illness, time from exposure to development of the first symptoms is called the incubation period. So from the time you come in contact with it until you first start getting sick, that's the incubation period of a disease of an illness. Uh, the interval in which the patient is shedding or release infectious materials is the communicable period. That's when the microbe can be potentially transmitted. That's whenever, we say that this is when you're contagious, right? This is when you can spread it. Factors causing infection and illness after exposure, virulence, dose, route, the body's resistance. So these are all factors of whether or not you're going to get sick from coming in contact with it. Severe infection, severe sickness is what we refer to as sepsis. So sepsis is a life-threatening condition that results from abnormal and counterproductive response by the body that causes damage to the tissues and organs. Basically, it is an immune attack on your body. So the body overreacts and secretes substances that instead of helping, they hurt the cells, that hurt the tissues, they hurt the organs. The body is trying so hard to get rid of whatever it is, whatever sickness or whatever disease that you have, uh, that they're attacking and they're shutting things down in the process. Uh, Septic shock is when it occurs when these changes result in shock and hypotension that does not respond to intravenous fluids. So you have your infection, which is a localized response. Then you have sepsis, which is a systemic response. That's where the body produces lactic acid, other chemicals. The body's ability to produce white blood cells has either been limited or has it been exhausted completely. So now your body is just pretty much in a free for all with itself, trying to kill itself to get rid of the disease. Is what it boils down to. What it's doing. Then you have septic shock, which is sepsis with hypotension, essentially. Locations of the body that are likely to be associated with sepsis, you have your lungs, so pneumonia can cause sepsis. Abdominal surgery and pancreatitis can lead to sepsis if not tended to appropriately. Uh, Kidney, prostate infections, urinary catheters that have become infected can lead to sepsis if not treated appropriately. Uh, Skin disorders, skin diseases can start leading to sepsis. Sepsis is still kind of a big unknown in the medical world of what the root ultimate cause of it is, what causes it to get to a systemic point versus a localized infection. There's a lot of research still going on trying to better understand this. So when assessing a patient you suspect of having an infection or having sepsis, you want to look for systemic inflammatory response syndrome criteria. So body temperature is either lower than 96.8 Fahrenheit or higher than 101 Fahrenheit. That shows the body is either compensating or potentially lost its ability to compensate. Uh, Sorry, every time I stop talking, I'm trying to hear what they're saying on the radio. Uh, Heart rate has been over 20, or is over 90. The respiratory rate is over 20, excuse me. Systolic blood pressure is lower than 90, and new onset of altered mental status or worse than altered mental status. This is your SIRS criteria. This is what determines basically whether or not you're going to call a sepsis alert or not. So you want to look for any kind of signs of sepsis in a patient you suspect having an infection, provide supportive care, treat for shock. If the patient meets SIRS or similar criteria, inform the ED, call a sepsis alert. The best way to prevent sepsis is preventative, or is best way to treat sepsis is basically to prevent it from happening in the first place. So you want to, in a healthcare environment, ensure that they're getting preventative care, they have the appropriate vaccinations, they've taken appropriate precautions, they're keeping clean, they're getting wound care appropriately, all that other stuff. Uh, you want to assess, has the patient traveled? Have they been exposed to something they haven't, otherwise been exposed to, some sort of disease that their body's not used to? Have they received vaccinations? Uh, Always make sure you're protecting yourself. So wear your PPE. Uh, if you come in contact with some sort of infectious disease, get preventative care. Take Get tested, all that other fun stuff. Like I say, if you come in contact with, say, tuberculosis, okay, uh, make sure you get TB tests and take preventative antibiotics. Make sure you don't get sick yourself. So, other diseases you may come in contact with, you have the chicken pox. That's caused by the varicella zoster virus or VZV. Uh, Usually it'll start off with cold flu-like symptoms, and then you'll start getting a fever accompanied with a rash that starts looking like blisters. It's very contagious. It can be spread from person-to-person contact, airborne contact, all that other fun stuff. The dried scabs from the disease do not spread the disease. By the time it gets to that point, it's already run its course. But if you're being around somebody, breathing the same air, touching them, all other stuff, fun stuff, can lead to you obtaining chickenpox. That's why it spreads through a house very quickly. As a child with chickenpox, you notice the red bumps all around them. Uh, Only way really to treat it, you have to isolate them until the lesions dry. Uh, Antiviral medication can sometimes shorten the course of the disease, prevent complications. And as always, preventative care is the best way to treat it by making sure you don't get it in the first place. If you are exposed to it, you need to try and receive the vaccine within 3 days of exposure. Measles, also called rubella, is a highly infectious viral disease you may come in contact with. It starts with a fever, cough, eye irritation. Uh, Then we'll have small white or bluish white spots on the inside of the cheek, a red blotchy rash. It spreads easily, and they're through inhaled droplets in the air. There's no specific treatment. The only way to prevent it is vaccination, quarantine, proper hygiene. it's not a very common disease anymore. Same with the mumps, also not very common anymore. Sorry, just give me just a second. So signs and symptoms of the mumps starts with vague symptoms such as muscle aches, loss of appetite, headache, progresses to swelling and inflammation of one or both parodids. Paroditis lasts 7 to 10 days. You'll start seeing they got swollen face, their cheeks are swollen up. Uh, it can be transmitted through direct contact with their saliva droplets. Can be breathed into the air. The only way to treat it is to prevent it. Again, get vaccination. This batch is stupid. All right, sorry about that. Hepatitis A is a general term that means inflammation of the liver. It's signs and symptoms include fever, nausea, loss of appetite, malaise, abdominal pain, jaundice. It's generally worse in older patients. Uh, there's no specific treatment. It's usually spread by coming in contact with fecal matter and ingesting it somehow. Prevented by hand hygiene, proper food preparation, vaccination. Hep B is very common in some parts of the world. A lot of the same symptoms. It's usually transmitted through blood contact, fluid contact, semen, cerebral spinal fluid, amniotic fluid, vaginal secretions, other fluids, things like that. Also, no specific treatment. Uh, Prevention is vaccination. Most EMS agencies require you to be vaccinated against Hep B before you go to work for them. Uh, take post-exposure actions to wash exposure sites with soap and water. See your healthcare provider immediately. Uh, get vaccinated if you haven't already been, and then there's possibly you might have to get some immune globulin injections as well. Hep C is similar to Hep B in pretty much every way. Uh, it is usually obtained through bloodborne transmission through shared needles. So the risk to us is a potential needle stick, right? Uh, there's several safe medication regimes you can take if you get exposed to it or contract it. There is no vaccine for it. HIV and AIDS, most people have heard of. For some patients, it may present with flu-like symptoms within a few weeks of HIV infection. Uh, HIV will progress into AIDS. AIDS is characterized by opportunistic infections. So HIV stands for human immunodeficiency virus, and then AIDS stands for autoimmune deficiency syndrome. So routes of transmission can be shared needles, unprotected sex, not just between men, between anybody that is infected. Uh, any penetrative activity involving blood and semen during delivery or breastfeeding from mother to newborn. Uh, Antiviral medications reduce and suppress the HIV viral load. So take standard precautions, take public measures to reduce shared needle use and promote condom use. Uh, Basically, again, like with some of these other things, the only way to prevent it is, the only way to treat it is to prevent it. Influenza or the flu, very common viral illness, fever, non-productive cough, muscle aches, sore throat, headache, severe weakness. It's spread by the droplets of direct contact. Uh, any antiviral medications that may be prescribed lessen the severity and shorten it, but must be taken within 48 hours. And also, they're not very commonly prescribed. Usually, you just let it run its course. Hand hygiene, wearing a mask, vaccination, stuff like that. That's the only way that you can really prevent getting the flu. Is to try and prevent any way of coming in contact with it and or to be vaccinated against it. Croup, very common, commonly affects children. Uh, includes inflammation and swelling of the larynx, trachea, bronchi. Most susceptible are children between 6 months and 3 years old. Uh, Usually they will have some sort of history of upper respiratory infections, later produces symptoms and characteristic steel bark cough. Symptoms often worsen at night. Transmission by droplets from coughs or sneezes that are survive on objects. So basically, all we're going to do here is we're going to treat the respiratory symptoms. It's not a whole lot we can do to stop, somebody or, treat the croup itself. We're going to treat any kind of respiratory symptoms that occur from that, just as we would treat anybody else with having respiratory problems. Pertussis or whooping cough is also very common in children. Begins usually as a typical upper respiratory infection. It'll worsen into fits of uninterrupted coughing, uh, uh, followed by whooping sound on inspiration. Usually it's treated by antibiotics, prevented with vaccine, hand hygiene, refrain from touching nose, eyes, and mouth. These are illnesses that are common with children. However, they can be, contracted by adults as well. Questions, comments, concerns so far? I'm sorry we're moving so fast, but we got a lot of stuff to cover. All right. So, may also have to be dealing with somebody who has pneumonia. Signs and symptoms can include fever, chills, shortness of breath, tachypnea or rapid breathing, pleuritic pains, pain with breathing, a productive cough, so coughing up some green, yellow nastiness, inflammation, consolidating part of the lung on an X-ray. This could also lead to potential febrile seizures in young children and infants, so fever-induced seizures. Altered mental status is common in elderly patients. You don't need to know what a chest X-ray looks like. So we don't have X-ray machines on ambulances, right? It's spread by droplets, but it does require close contact of several days. It's not a very highly communicable disease. Uh, it's treated with antibiotics, uh, preventative techniques, essentially. Tuberculosis, however, is highly contagious. It's caused by bacteria. Signs and symptoms are cough, which is initially dry. Uh, Later, it kind of turns into productive cough, fever, night sweats, weight loss. It's spread by coughing, sneezing, singing, I guess. Treatment with antibiotics, prevention with a vaccine. Most companies also require you, most EMS agencies will require you to get a TB skin test on a very regular basis. Sometimes you may have to deal with somebody who has meningitis. There's a couple different types of meningitis. So there's bacterial meningitis. Signs and symptoms of it are abrupt onset of fever, nausea, vomiting, severe headache, uh, light sensitivity or photophobia. Uh, may have a petechial rash, shown here, very splotchy. Uh, Meningitis is spread by direct contact. Treatment is with antibodies. It's prevented by a vaccine. It's very deadly if you contract it. Uh, Sexually transmitted infections. You have your HIV, hepatitis A, B, and C, genital herpes, HPV, bacterial. You have chlamydia, gonorrhea, syphilis. Preventative sexually transmitted infections. You just have condoms and vaccination for some of them. STIs are not a common reason for a patient to call 911, uh, except for women who occasionally will develop pelvic inflammatory disease or PID. It's usually caused by gonorrhea or chlamydia. It causes severe lower abdominal pain that they may not associate with increased vaginal discharge. They may not realize that it's connected to a sexually transmitted infection. Anybody have any questions, comments, concerns over anything we've covered tonight? All right. Thank y'all for bearing with me. Sorry I had to cut in and out a couple times. Like I said, I'm on duty with the police department right now. If y'all have any questions, feel free to post them in the group chat or message one of us directly, and we'll be happy to answer them. Y'all have a good rest of your evening.